Hello, I'm Dr. Peter Steinmetz, the Director of Undergraduate Point of Care or Bedside Ultrasound Teaching at McGill University. And I'm here to discuss with you a couple of things. First of all, I want to give an introduction to how we feel that bedside ultrasound can improve a student's ability to learn anatomy and to improve their clinical assessment. Secondly, I want to describe how one can start an undergraduate curriculum, how to integrate bedside ultrasound into an already very complex and full curriculum. And then lastly, how one can develop faculty and the resources necessary to teach bedside ultrasound. So firstly, in terms of does ultrasound improve a medical student's understanding of anatomy, there are quite a few studies, some of which I've mentioned here, which describe a medical student's description of their self-description of whether the use of ultrasound during their training at different parts of their undergraduate training improved their understanding of surface anatomy and also internal anatomy. But these are all self-descriptions. There is one randomized trial that came out in abstract form in 2011 in which a class was divided into two. One group received ultrasound training and the second group did not receive ultrasound training. This was during an anatomy class, and the students who received ultrasound training fared significantly superior on an examination at the end of the course. At McGill, our experience, self-description from students after each of our modules in first year, this was from the first year we integrated the ultrasound course in 2013, the students described that 95% of them felt that the ultrasound course improved their understanding of anatomy. And certainly, anecdotally, our experience has been that there are a high number of what I would call eureka or aha moments in students when they look at the ultrasound image, look at their probe on the surface of the patient, and understand finally where the liver sits, for example, where the spleen sits within the patient's body. When you ask, does bedside ultrasound make a student more accurate as a clinician? The answer from the literature is yes. In the study by Muratev that I cite here, medical students were more accurate in determining liver size using a bedside ultrasound handheld machine when they were compared to internists who used the classical physical examination techniques in order to determine liver size. In the study by Kobal using cardiac patients, again, medical students were taught how to use a handheld ultrasound device to identify different cardiac pathologies, and when compared to board-certified cardiologists who use physical exam alone, the medical students using the handheld ultrasound machine were more accurate in identifying the cardiac pathology. Similar to that, the DiCara study describes a course in medical students where they compared the accuracy of medical students at the bedside to make cardiac diagnoses when they used physical exam alone as compared to bedside ultrasound as an adjunct to their physical exam. And indeed, they found that the students using bedside ultrasound as an adjunct to their physical exam were more accurate than when they used physical exam alone. In a study that we are soon to publish, we took medical students in fourth year to a hospital and we introduced them to hospitalized patients. And half of these patients had pleural effusions or fluid around the lung. And we asked our medical students to examine the patient and divide the chest into two hemithoraces. And they were asked the question, is there pleural effusion on the left side, yes or no? And is there pleural effusion on the right side, yes or no? Using all of the physical exam techniques that they've learned in medical school, including inspection, palpation, looking for fremitus, auscultation, percussion, the classical percussion, as well as auscultatory percussion. And then after they had determined whether there was a pleural effusion, we asked our students to then use the ultrasound machine. We had taught them a simplified way of examining a hospitalized patient looking for pleural effusion. And this table shows you the results. In short, the accuracy of the physical exam with ultrasound as an adjunct was 88%. The physical exam alone, its accuracy in identifying a pleural effusion or the absence of a pleural effusion was 60%, so a significant difference. So that's a summary of some of the evidence for why we're teaching medical students bedside ultrasound. Our point of view is that if the medical students are more accurate clinicians when using bedside ultrasound as an adjunct to the physical exam, why would we not teach them? Our feeling is that it's an important skill for future medical practitioners to learn. So how do you start and integrate an ultrasound into a very full curriculum? Well, to give you our timeline, in 1829, McGill was established as a medical school, and it went through many incarnations, but in 2012, there was a curriculum revision, and a number of us made the proposal that bedside ultrasound should be part of that curriculum. And it was accepted such that we started teaching in 2013 our first course at McGill. By 2014, we already had medical students who were presenting research at the World Congress of Ultrasound and Medical Education. And by 2015, we had some medical students who were joining us as apprentice instructors. By 2016, the fourth year of our program commenced, and we had again more residents and students come to the Fourth World Congress that was held in Texas. In 2017, we have our graduates, in other words, our entire four-year class will now, fourth year class from now on, will have had 4 years of ultrasound training at McGill University. So how is it integrated? Well, we are the first university in Canada to have a 4-year ultrasound curriculum. We published a national survey in 2016 that documented that. We also have a 2-year family medicine residency bedside ultrasound program at McGill. The way we integrated it into the curriculum, it's not necessary to understand this whole table, but suffice it to say that what we wanted to do is tailor our teaching to whatever was being taught in the curriculum. For example, if the students were learning about the nephrology or kidney physiology and anatomy, it would be during that week or that month that they would also receive the bedside ultrasound training with respect to kidney, so kidney imaging, for example. So it was integrated and tailored to the curriculum. Just to give you an overview, our first year we have a module on dyspnea, how to approach a dyspneic patient, how to approach a hypotensive patient, and 2 modules on abdominal pain. The first on looking at the aorta in terms of thinking about an aneurysm, and the second looking for free fluid in the abdomen. Then we have a kidney injury or an approach to kidney injury. All of our modules are approaches to common problems. So approach to kidney injury using bedside ultrasound as an adjunct, and then approach to the painful knee. We have a review session where the students are able to review all of the modules that we've covered in the year, and we have an OSCE at the end of the year. Very important in first year, we make sure that the students understand that the ultrasound is used as an adjunct to the clinical assessment. In other words, we make very clear that an excellent history, an excellent physical exam precedes the use of the ultrasound. So the ultrasound is only useful as an adjunct to the entire clinical assessment of the patient. In second year, we have our modules within a surgical teaching block. So in that session, we talk about abdominal and pelvic pain, in specifically looking at the gallbladder in the context of someone you suspect cholecystitis, looking at the pelvis for pelvic pain in somebody whom you're worried about an ectopic pregnancy, and lastly, abdominal pain in somebody who you are suspecting a AAA, which is a review of what was covered in first year. In third year, we talk about ultrasound-guided procedures, including thoracentesis, paracentesis, central line, and peripheral venous access. In fourth year, we introduce the concept of echo-guided life support, which is an algorithm which examines how to use ultrasound in the context of a shock patient. And this occurs during the emergency medicine month that the students have in their clerkship training. All the course components of each section are aligned. So here we have an ultrasound textbook. So the students arrive having read the textbook, having done the classroom reading at home, having looked at the videos of ultrasound images at home. They then have a pre-test, which is online, which is completely correlated to the textbook. So in other words, it comes right out of the textbook. And then the post-course test is also aligned with the textbook. And finally, any evaluation they have in the OSCE is similarly aligned to the pre-post test and the textbook. So here's an example of a chapter on lung sliding or lung ultrasound in a dyspneic patient next to the objectives, which are sent to the students. So in other words, the students read the textbook, they receive the objectives, they understand what objectives will be acquired during the course, and then the objectives are then tailored to the pre and post-course tests. And those tests are furthermore correlated or aligned to the instructor evaluation form, which is seen here. So everything is aligned. When we assessed our course after the first year, we wanted to know, did the students acquire the skills that we had set out for them? And the answer was yes. If you look at this table, if you agree and strongly agree as being positive, then the instructors felt overwhelmingly that the students did acquire the skills necessary in each of these 6 modules. We also wanted to know whether the students retained those skills. So the first study, we looked at whether the students acquired the skills after the course, the same day of the course. But 8 months later, we looked at whether those skills were retained. And indeed, we found that at 8 months, again, if agree and strongly agree correspond to a positive outcome, then the vast majority of students retained the skills for that module. So how do you develop faculty and resources in order to have such a curriculum? If you look over Canada in 2014, about half of the medical schools had in red ultrasound curriculum. That is now increased. We're now 3 years later already. So this was part of a survey we made of different medical schools in Canada. And it was clear that there were obstacles to integrating bedside ultrasound. And when we asked the medical directors, the undergraduate deans of these medical schools, whether they felt that bedside ultrasound teaching was a good idea, the answer was essentially yes. In the responding schools, if you look, bedside ultrasound is a useful adjunct to the physical examination. 100% of those schools felt that yes, it was. And if we asked those associate deans whether this bedside ultrasound education should be a part of the medical curriculum, 77% felt yes. Despite that, we saw that only 50% were integrating bedside ultrasound in some manner during undergraduate curriculum. And so we then wanted to know what were the obstacles, and the obstacles were the lack of infrastructure, the inadequate time in the curriculum, and lack of qualified instructors and faculty support, as well as some people felt there was inadequate evidence for the usefulness of bedside ultrasound in students. What we did in terms of developing faculty is to start courses, because what the feedback we had from faculty was that they were uncomfortable with students arriving with bedside ultrasound skills that they could not supervise. And so we introduced continuing medical education courses, which we called the MUSE 1.0 and 2.0. MUSE stands for McGill Ultrasound Evaluation Course. And this course aims to teach staff physicians the essential skills in bedside ultrasound. It's a hands-on 2-day course where they have about 15 hours of hands-on scanning at our simulation center. It's accredited by the Canadian Family Physicians of Canada, and we've had over 200 participants to date. This is a picture of some of our instructors at a course. We also wanted to develop near-peer teachers because we found that having student and resident instructors was very enriching for the program in many ways. The instructors themselves were able to improve their teaching skills and improve their mastery of the subject matter. But in addition, the medical students who had near-peer instructors felt that the instructors gave them the confidence really to acquire the skills, because when they saw a student or a resident teaching, they realized these are skills that I can also acquire. And also the feedback was that the students and residents made them feel comfortable to ask very basic questions. So here we have a picture of some McGill students who are teaching other medical students at a medical student conference in Quebec. When we did a study looking at what the students felt, here you see in green and yellow, you can see that with respect to different parameters, the students did feel that the near-peer teachers, if you consider good and very good to be positive outcomes, then the students felt that the near-peer teachers were comparable to the staff instructors. The only significant improvement was it in the knowledge category here, where you see that the staff instructors were considered more knowledgeable, and that was usually because the instructors were able to give more clinical scenarios in which the ultrasound skill was useful. Although the actual teaching of the skill was comparable, the knowledge of the subject matter was seen to be more sophisticated. And how else do we develop ultrasound interest? Well, we had an ultrasound interest group made up of students and residents. This was purely initiated by them, and we held a conference to help them have further training, further access to practicing the skills that they acquired. We also develop resources by securing and locating an infrastructure. We also already have the McGill Simulation Center, which was very, very cooperative in helping procure the funds to purchase 8 ultrasound machines, which are now on site, and as well as ultrasound simulators, which are on site at all times. We also have standardized patients who are scanned when the simulators are not being used. We develop resources by using our own textbook. This is a textbook that I wrote, which is available in English and French, as well as on iBook, and the EGLS Echo-Guided Life Support textbook written by Dr. Langto and Valois, which we use for our 4th year course. So we realize that there is a lot of information online, but it's difficult to tailor the online information to the course that you designed for your undergraduate curriculum. The future challenges that we see are that we'll have to secure an adequate number of instructors to prevent instructor fatigue. we do tend to see the same instructors at many of the different courses, and after 4 years, people are less willing to teach on every single course. So I think it's very important to build up a roster of excellent teachers. One way that I've been doing that is to set up a near-peer teaching group where I give tutorials to apprentice instructors who want to be involved. So once I've instructed and given a tutorial to the student or resident, and I've vetted their teaching skills, that student will be an apprentice instructor with a supervisor, and after several sessions, that student or resident near-peer teacher can teach on their own. We have to align the undergraduate and postgraduate curricula. What we are finding is that as the students graduate from 4th year after 4 years of training, we no longer need to teach a basic bedside ultrasound course to the first year family medicine residents. Those residents now need a more sophisticated course. We need to improve staff and physician comfort with bedside ultrasound, and the way we've done that is to set up our CME course, the Muse 1.0 and 2.0, in order to familiarize the staff with bedside ultrasound skills. We have to find simulators to use so that we can improve the amount of time students have to practice, and the simulators are also able to generate images of pathology. So we are in the process now of increasing the amount of simulated learning we are using at the simulation center. And also teaching ultrasound in remote universities is something that is of interest to us, and we've been doing research into telemedicine teaching with different platforms, and we have found that it is possible to teach remotely certain ultrasound skills. And lastly, I'd like to just say that we're very proud to be hosting the World Congress of Ultrasound and Medical Education that will be held in October of 2017 in Montreal. This is a great congress where we'll have international level speakers, plenaries, and hands-on workshops, and a great chance for medical students and residents to submit abstracts as well for ultrasound-related research. And lastly, there is a World Cup of Ultrasound in which medical students from different universities can compete in a light-hearted competition against other university medical students with regards to ultrasound skills. So I hope to see you all in Montreal in October of 2017 for the World Congress of Ultrasound and Medical Education. It's timely for us because it's an anniversary year in Canada and for Montreal, and it's also an anniversary year for our undergraduate medical bedside ultrasound curriculum. It's the 4th year of our curriculum, so our current students are graduating with 4 years of bedside ultrasound training at McGill as of this year. So with that, thank you very much and for attending the webinar. If you have any questions, don't hesitate to email me, and I'll be happy to get back to you with any answers to your questions. Any comments as well would be welcome. Appreciate your time.